All right. So we are at 1:33, so we can go ahead and get started. I'd like to welcome everyone who has joined today to our webinar series. And today's focus of the webinar is Introduction to Phenotyping in All of Us. I'm Dr. Sula Hood, and I serve as the co-lead for the All of Us Researcher Academy, who is hosting today's webinar. Just before we move forward with today's presentation, I'd like to share a brief overview of the All of Us Research program, as well as a little bit of information about how our Researcher Academy fits in. The National Institutes of Health All of Us Research Program is a historic effort to collect data from 1 million or more people around the country to learn about health conditions and to learn about how to improve people's lives. A goal of the All of Us research program is to speed up health research discoveries and enable individualized medicine and advanced precision medicine. So, a little bit about how our Researcher Academy fits in. Our Researcher Academy provides training and technical assistance for researchers who are conducting research with the All of Us Researcher Workbench. And that's the cloud-based platform that houses participant data for all of us. And I'll share a little bit more about that here shortly. A little bit more about our Researcher Academy. We're very focused on reaching as many researchers as possible to connect them to the data set. And so we support peer-to-peer learning and network building among researchers and students. To learn more about the Researcher Academy, please scan the QR code below. Okay, so a little bit more about the All of Us Researcher Workbench specifically. As I mentioned, the Researcher Workbench is a cloud-based platform that houses all of us participant data. Researchers are able to access this data when they register to sign up for the Researcher Workbench. There, as a centralized platform, the Researcher Workbench houses data at two different levels. There's the registered tier, which includes participant information related to electronic health records, wearables, and surveys and physical measurements. And then the controlled tier houses more sensitive data, including genomics data and genome sequencing. As you can see here to the right, there's a wealth of data available for researchers to analyze and make health discoveries. Over 630,000 survey responses, as I mentioned, physical measurement data, electronic health records data, as well as genomic data. Okay. Um, Over the past several years, during our Researcher Academy, we've had the pleasure of designing and hosting courses on a range of topics to benefit researchers. These researcher course materials are available online and can be used asynchronously, and they're available through our Amaze platform. We do have a catalog available that provides information about all of our courses that we have available, information about the instructors that teach the courses, and all of that different type of information. When individuals first go to our course catalog, for people who are not signed up for the Amaze platform, please do not worry. You're able to sign up. There's no charge to it. And on our first page, we do include instructions about how to sign up for Amaze because that is required to be able to access our courses. To learn more about Amaze as well as to access our course catalog, please scan on the QR code on this page. Okay. And finally, another resource that I'd like to highlight from our Researcher Academy is our All of Us Researcher Academy newsletter, which is called Connections. It's a quarterly newsletter that features information such as researcher spotlights to highlight the accomplishments and the research of individuals who are connected with our Researcher Academy. We also include announcements about Academy events such as this webinar series or other types of activities that we host, as well as also share information about upcoming events for our partners, including the larger All of Us research program. To get more information about our newsletter and to also sign up, please scan this QR code. And we are a growing network with over 850 subscribers. So we do encourage anyone who's not signed up to please go and sign up and subscribe. We have had the pleasure of doing some amazing and impactful work over the past several years throughout throughout the past several years, excuse me. We have a strong and mighty team behind all of this work. I'd like to acknowledge my co-lead, Dr. Brian Southwell, as well as our lead coach for the Researcher Workbench coaches, Dr. Javon Carter, who is very pivotal for the work that will be covered today. Okay, and I'd like to now introduce our speakers for today. Today's webinar will focus on an introduction to phenotyping in all of us. Today, we have the pleasure of hearing from Angela Gasdaska and Daniel Brannock. Angela Gasdaska is a research data scientist at RTI International. She serves as a researcher workbench and AI machine learning coach for the Aim Ahead All of Us research training program, where she trains researchers to use the workbench and apply AI and machine learning methods to all of us data. Her research experience includes extensive analysis of electronic health records data, and she has led the data analysis for a study using the All of Us database examining the association between GLP-1 medication use and alcohol consumption. Daniel Brannock is also a research data scientist at RTI International. His research has focused on applying statistical and machine learning methods in All of Us and other large-scale repositories of electronic health records. His primary interest is in adapting established methods for use with observational records not originally collected for the purpose of research. Mr. Brannock has developed coursework for the Aim Ahead All of Us training program and helped develop an R package to evaluate the generalizability of prevalence estimates from all of us. I'd like to once again just welcome everybody, and we're very appreciative for Angela and Daniel presenting today. For our participants, throughout the session, you're more than welcome to ask any questions that you have. We will get them in the chat and address them during our Q&A session. And I'll pass it over to you, Angela and Daniel.
Thanks, Sula. So hi, everybody. Thank you for the introduction, and thank you for being here, all the attendees. So I'm going to talk a little bit about the background and motivation first for the talk. And we want to start by defining phenotyping. So this presentation is going to be hopefully instructing you on how to build better phenotypes using all of us. But what is phenotyping? And that's typically the word that we use to describe the process for using data to identify individuals with a specific condition. Although it doesn't necessarily need to be a condition, it could also be those who are taking a certain drug or have had a certain procedure. It's really the process of identifying individuals who have some trait that you're looking for in the data. Phenotyping is foundational and is usually the first step in any EHR-based research. And it's particularly important when you're using research, when you're using EHRs like in All of Us, because that data was not collected for the purposes of doing research. It was driven by treating patients and billing payers. And so there are gaps in the data. There's underdiagnoses, there's disparities in access, there's a lot of missingness in that data. And there's also inconsistent coding across different providers, different hospital networks, even over time within the same provider or hospital. So when you're using all of us data, or in particular the EHR data within all of us, there is almost always not one single correct definition for whatever thing of interest that you're trying to define. So what we're going to talk about are some of the Workbench tools and vocabularies that help you in defining those cohorts and hopefully making it not too overwhelming, because I think when you first start looking at those vocabularies, it can be a lot. So let's go to the next slide. We're going to keep touching back on three examples. Oh, can you go back one, Angela? Or did you go, you went for two? Okay, this is perfect. So the objective today is to equip researchers to ask the right questions when developing a phenotype and then give you a framework for answering them. So we don't expect you to come out of this knowing exactly what to do and the answer to every question for the phenotype that's relevant in your research, but we hope to give you the right tools to answer the questions that are important to building that phenotype. So let's go to the next slide, and we'll touch on three examples over the course of the presentation. And so if this isn't one of the things that you're interested in, that's fine. These are just meant to be illustrative for how you might ask the right questions, then how you might go about answering them. So the three conditions that we're going to talk about are type 2 diabetes, depression, and then not a condition, but users of GLP-1 drugs. And each of these are actually available as community workspaces. For most of these, for the first two, we use some existing phenotype workspaces within all of us and adapted it for our purpose and then published those results in a community workspace. And then for the GLP-1 users, we defined it de novo for our project. And you'll have access to these slides after, and so you can click on these links and actually look at exactly how the cohorts are defined within those community workspaces. Okay, so the overall step here, this is just a high level overview. What are the steps in generating a phenotype? So this is the overall framework. Well, first, you need to define your research question and ask yourself how the phenotype is going to be used. Second, you can search for existing validated phenotypes and resources. It's almost never a good idea to start completely from scratch. And we'll talk about how we didn't do that exactly for GLP-1 users, even though we didn't have a phenotype workspace to work from. Third, you can explore what data are available in All of Us, and don't limit yourself to the EHRs. One of the exciting things about All of Us is that it has these other data sources that Sula mentioned, the surveys and genomics data, and wearables and other sources. Fourth, we're going to outline some of the phenotype requirements, which is going to change based on whether it's a condition or a drug or a procedure. Fifth, create clinically reviewed concept sets. And the word clinically here is really important. So having that multidisciplinary team that you can get somebody with clinical experience on your team who can look at concept sets. And then finally, how you actually go about implementing that phenotype in All of Us. Okay, step one, define your research question and how the phenotype is going to be used. So these are just some of the questions that you can ask yourself. But what is the role that your phenotype is going to play? Is it going to be an outcome that you're attempting to measure? Is it going to be an exposure that you're trying to measure the effect of? Is it just a baseline exclusion? Maybe some people should not be included in your analysis because they're not eligible for a certain medication. Or is it just something that you want to control for in your analysis? These are all different roles that a phenotype could play, and they might have different consequences for false negatives and false positives. So we're going to harp on this for just a moment of that difference between being wrong about somebody being included in your phenotype or leaving somebody out who should have been in your phenotype. Oftentimes, this is not a symmetrical mistake, right? A false negative may be more problematic or less problematic than a false positive. And then finally, what scientific question are you trying to answer? Are you evaluating a treatment effect? Are you estimating a prevalence? Are you just trying to build a cohort with a certain disease so you can characterize progression of that disease over time? And it's more descriptive. Go to the next slide. Okay, so this is as we ask ourselves these questions for some of our examples that we mentioned at the top, you can see what we considered important for each of those for each of those use cases. So unfortunately, we don't have time to go in detail through everything on this slide, but we hope this will be a good reference. But let's look at least this first table here, which is looking at the phenotype role for an outcome versus an exposure versus a baseline exclusion versus a covariate or control, something that you're trying to control for an analysis. So if you're building a phenotype to use as an outcome, so you're trying to evaluate who has this outcome that we're interested in, you might emphasize high specificity. You really don't want to have false positives that are going to dilute the effects of whatever you're trying to measure. If you're trying to evaluate an exposure, that could depend a lot on the study question. So it may be that biasing towards a diluted effect is actually conservative, and that's the approach that you want to take, or it may be the opposite, and you want to really emphasize that there's a potential for harm here. So that just depends on your specific research topic. If you're trying to evaluate a baseline exclusion, then you very often do not want to miss people who should have been included as that exclusion, right? You don't want to include people in your analysis who are not eligible for inclusion in that analysis. So it may be worth dropping some people that you would have otherwise been unsure about to make sure that you didn't include anybody who should not have been included. And then for if you're trying to control for a condition, then very often this is one of those cases where you do have a relatively balanced uh, uh, error between false positives and false negatives, where if you emphasize one over the other, then you're going to actually bias your model. But if you have a somewhat balanced error, then that's actually going to get you a better, more accurate exposure effect for whatever you're actually trying to evaluate. Let's and then briefly, we can just talk about some of our examples here. For depression and type 2 diabetes, for those examples, we were estimating prevalence. And so we wanted to have a nice relative even balance between sensitivity and specificity. For the GLP-1 projects, we actually did two of them. For one of them, it was just characterizing a population. And so we wanted to make sure that everyone in that population that we were evaluating was actually taking GLP-1s. So we had a much higher weight on specificity, meaning that false positives were much more problematic for us than false negatives. And then in our other GLP-1 analysis, we are looking at the effects of GLP-1 on alcohol consumption, where again, we are sort of putting a higher weight on specificity because we needed to make sure we evaluated uh, the effect of GLP-1 among GLP-1 users. We didn't want to accidentally include somebody who wasn't even taking GLP-1s. Let's go to the next slide. Okay, step two. This is, again, in that overall framework. The next step, once you've asked yourself your research question, you can start searching for existing phenotypes and resources. And we're pointing out two different resources here. There are certainly others, but these are the two that we have found useful in our work. And in particular, this first one, the Value Set Authority Center. And there's a link here so you can go and you have to sign up for an account, but it's free. And once you have an account, you can search for a condition. So here we've just searched for type 2 diabetes. And what you will see is a bunch of different options come up. And that code system column on the right of that VSAC box there tells you what vocabularies are being used for each of those code sets. And so if you need a list of ICD-10 codes for a given condition, such as type 2 diabetes, this is a really, really good starting point. However, it's worth emphasizing that this is just a starting point. And depending on how you defined your research question, you may want to take some codes out. So you may want to take out codes that are just history of diabetes without actually an acute diabetes diagnosis at the time. Uh, Very important to find these starting resources and curate them for your specific problem. It's actually pretty rare in my experience to be able to pull one of these off of VSAC and use it as is. But it is very common to pull one of these off of VSAC and have it serve its purpose, get it reviewed, and then use it going forward. Let's go to the next slide. Okay. So how do you actually make sure your code set is good enough? And for this, unfortunately, we often just can't do it ourselves. So Angela and I, for instance, are both data scientists. However, the best people to review a code set are often clinical experts who are using these codes every day for the treatment of patients. And they can tell you information that you may not have known going into the project, such as when was a diagnosis code introduced? I've been involved in some long COVID research, and long COVID research started before there was a long COVID diagnosis code. That's relevant information for us, the research analyst. They can tell you about how often lab tests are administered, whether medications are ongoing or they're often intermittent or if they're being used off-label. And then geneticists can help you identify which genetic variants might help you identify cases that you're interested in. So all of these are important for every condition, essentially getting a holistic view of what has been done before and how it informs what you're doing next. So for depression, we know it's underdiagnosed, especially in the hospital networks that are providing data to all of us that are often not mental health providers necessarily. Let's go to the next slide. Okay, exploring what data are available in all of us. Um, for this, we like to start with the data browser. And the data browser is good in that it doesn't require necessarily an exact match. So if you search diabetes, then it returns conditions, it returns lab measurements, it returns procedures, and it will often return results for aliases for whatever you're searching, which is really, really nice and not necessarily the case with some other tools like Athena. But it also helps you answer some really concrete questions like, does this condition appear in the EHR with the prevalence that you would expect given your conversations with clinicians? Does it tell you if a condition code exists at all for that condition? And if it doesn't, are there other terms that you need to search to find whatever it is that you're looking for? The surveys very often have information on conditions of interest that are self-reported and therefore more complete because lots of people get diagnosed that may have been diagnosed in other healthcare systems. They don't appear in the EHR for one reason or another, but they can report that they do have, for instance, depression. And they can tell you if there are any lab tests or medications available. Okay, I'm going to pass it off to Angela.
Yeah, all right. Thanks, Daniel. So, good afternoon, everyone. Great to be here. So, to really dive in and make full use of the All of Us EHR data, it's really important to understand a little bit about OMOP. So, All of Us uses OMOP, the OMOP Common Data Model, to standardize its EHR data across healthcare systems. And OMOP provides two really key things. So, first, it provides a standardized data structure. So, data are stored in a relational database with specific tables for different types of information. So a different table for conditions versus drugs, for example. And each table also has standardized fields. So, a diagnosis from Kaiser Permanente and a diagnosis from the Mayo Clinic, they're going to be stored in the same table in the same format. The second key thing that OMOP provides is standardized medical terminology. So different healthcare systems use different local terms for the same condition. So OMOP maps all of those local terms to one standardized term. So OMOP really matters because it determines how EHR data are stored, structured, and interpreted in the All of Us Researcher Workbench. So if you don't have a decent understanding of OMOP and its structure, it's kind of hard to know where to find the data you need and how to query it effectively. So let's look a little bit deeper into the data standardization aspect of OMOP. So, like I mentioned, in OMOP, data is stored in a relational database with many different tables that you can connect. So these are just a few of the tables in OMOP, some of the ones that might be more important for phenotyping. So there is the condition occurrence table that contains diagnoses and problem lists. This is kind of usually your starting point for identifying people with the condition. There's the drug exposure table that contains medication orders, prescriptions, that kind of stuff. There's the measurement table that has lab results, physical measurements, vitals. That's where you'll find things like BMI or A1C for type 2 diabetes. We also have the procedure occurrence table that has procedures and surgeries. And then there's the observation table, which contains things like survey responses, lifestyle facts, family history, that kind of stuff. And then every single one of these tables has some common fields that are really crucial for phenotyping. So just to point out a few, we have the person ID. That's where you can enables you to link records across tables so you can connect a person's diagnoses to their medications and to their lab results. There's also date fields, and these are really important when you're getting into developing a phenotype with temporal logic, which we'll talk about in a little bit. And then there's also the concept ID fields, which are the standardized unique number assigned to each medical concept in OMOP. And these concept IDs are kind of the key to querying specific data. So let's dive a little bit more into those. So as I mentioned before, OMOP standardizes its medical terminology. So this means in the OMOP model, there are both source concepts and standard concepts. So source concepts are the original codes used by the healthcare provider in the EHR. So those are things like commonly ICD-10 codes for diagnosis codes, for example. And then the standardized concepts are harmonized common vocabulary codes used to enable consistent analysis across data sources. So all the different source concepts are mapped to these standard concepts. And when you're working with EHR data in all of us, it's really important to prioritize using the standard concepts because this ensures you capture all individuals that might have a condition regardless of the type of source code their particular health system might use. And then in the actual OMOP table within all of us, the standard concepts can be found in those concept ID fields, which I touched on in that previous slide. So, and another really important thing to understand about OMOP concepts is that they do have a hierarchical structure. So they have ancestor-descendant relationships. So for example, like type 2 diabetes with complication would be a descendant of type 2 diabetes, which would then be a descendant of type diabetes in general. So you kind of get more specific as you go down the descendants. And like using descendants and taking a look at them can be pretty helpful to ensure that you're capturing all specific, maybe subtypes of a condition, but they are something to be careful about, and you definitely want to do a careful review of any that you include because sometimes descendants can be just completely irrelevant to the condition that you are studying. So I think, there's definitely a lot of complexities to OMOP and all of its concept standardization. We don't have a ton of time to really dive in more than that. So I wanted to point you to a helpful resource, which is Athena. Athena is the official OMOP vocabulary browser. So you can use Athena to search for concepts by name or code. You can inspect hierarchies in Athena. You can also helps you to understand the mappings between source codes and standard codes. So I think it's really incredibly useful, and I highly recommend it using it when you're building your own phenotypes. So that just about wraps up step 3, which is understanding the data. So let's move to step 4. So step 4 is outlining the phenotype requirements. So this is the step where you get into the details and really come up with your exact phenotype definition. And this step should really be guided by everything you've learned in the previous steps. And generally, there are kind of 4 key areas to think through when defining phenotypes. And those are 1, the number of codes or diagnoses to use, 2, any temporal requirements like time windows or baseline periods, 3, if you should require multiple different domains like both medications and diagnosis codes. And then the 4th is, thinking about if the diagnosis code setting matters. So let's break down each of those considerations into a little bit more detail. So first, maybe to go a little bit deeper into the number of codes to require. So a single code might be okay for highly specific conditions or conditions that are rarely miscoded, or when you're using confirmatory evidence as well. So you're, maybe using a diagnosis code and a lab, maybe one diagnosis code is okay. Requiring multiple codes, typically 2 or more, is going to reduce false positives. So the more codes you require, the higher the specificity, but the lower the sensitivity. So as you require more codes, the sample size is going to drop, but you'll be more sure that the people that you have are actually have the condition. I think a very typical definition and use is to use 2 codes that are on separate days. Another really big area of consideration is temporal requirements. So some things to think about with this are, first, if you do want to require more than one code, think about if you should require them to be on separate days or a minimum number of days apart. We typically recommend at a minimum requiring codes on different days. And this just really ensures that you're capturing distinct clinical encounters and not just multiple billing records from the same visit. You can also consider time windows, meaning requiring codes within a certain period of time. That can be important for verifying persistent conditions. Also want to think about if your study will have a baseline period and if you need to require a diagnosis code to show up in that baseline period. I think there's also importance in understanding the difference between incident and prevalent cases and what your study requires. So incident cases typically require a clean look back period to confirm there were no prior diagnoses, where prevalent is a little bit more flexible in what to require. And then finally, one more thing to just note about temporal requirements is that in all of us in particular, it's important to consider enrollment timing, especially since all of the surveys are really taken at the time of enrollment. So if you're thinking about linking survey data with clinical data, you might want to require a diagnosis code or some kind of EHR code around the same time as this person is enrolling in all of us. Another really big area for consideration is using multiple domains in your phenotype. So using a single domain, like only diagnosis codes, is often simpler, but it can be a little bit more susceptible to miscoding from billing errors or whatnot. So triangulating evidence across domains can increase your confidence or specificity. So for example, requiring a diagnosis code and a medication, or a diagnosis code plus a lab result above a certain criteria can give you kind of stronger evidence that someone truly has the condition that you're studying, but it could reduce your sample size. Something else to consider with multiple domains is having sort of multiple pathways or different case definitions for your phenotype. So this could be, instead of requiring a diagnosis and a medication and a lab, you could be less restrictive and say, you want your participants to either have a diagnosis code and a certain medication, or maybe a diagnosis code plus a certain lab result. So this gives people, more ways to qualify for your phenotype, and it will increase your sample size while still maintaining some level of confirmation or confidence in your phenotype. And one really important thing to consider before requiring any particular domain is data availability. So if you're seeing that very few participants have a certain lab test, maybe it's not the greatest idea to require that, as often missingness isn't random and could introduce some bias into your study. And then finally, the last area of consideration we'll cover today is diagnosis source or setting. So this is where you consider if the setting of your diagnosis codes matters. So for example, codes recorded in inpatient settings are typically more accurate and often indicate greater severity. So for acute conditions like stroke or heart attack or sepsis, inpatient diagnoses are where the condition is typically first identified. But if you're seeing these diagnoses in outpatient settings, that might mean that this was follow-up care for that acute condition or some kind of rule out. Something else to consider is whether the diagnosis was from a specialist. So specialist diagnoses are often more reliable for conditions that are complex or rare. So that is something to consider. So for example, for lupus, a rheumatologist specialist diagnosis might be more accurate than a primary care one. But now that we've gone over some key areas of consideration, let's see how these apply to some examples. So first, we'll start quickly with HIV. We've really put this phenotype in here to show just how complicated phenotyping can be. So you might think that HIV would be, a straightforward phenotype to define, but it's actually quite complex, as you can see by this chart. So you have to consider, multiple data domains and also what to do when participants are missing certain data elements. So this really just illustrates that phenotyping can be quite complex and really requires deliberate design choices at every step. So now let's move on to the three examples that we actually touched on earlier on that we have actually developed. So first, starting off with type 2 diabetes. So if you'll remember for this, we were estimating prevalence. So we wanted to balance sensitivity and specificity, meaning we want reasonable confidence that the people we are including actually have type 2, but we don't want to have a really strict definition that may exclude a lot of people that do actually have type 2. In addition to that, we want to keep in mind that this is a chronic condition, so we'd expect to see a lot of evidence for it over time. And we also want to make sure we're looking at conflation. So type 2 can sometimes be conflated with type 1 or be misbilled with a type 1 code, so we want to be careful about that as well. So with keeping that in mind, we decided to go with a definition that includes alternative pathways or case definitions. So for our phenotype definition, we had three different kind of pathways that someone could qualify for our phenotype, and they each require different data domains. So I think for this, we were really hoping that, with requiring multiple domains at every step, this increases our confidence that these individuals do actually have type 2, but having these multiple different case definitions ensures we aren't excluding participants that may be missing certain data domains for whatever reason. And then, of course, there's something to note that we also made sure to exclude participants that had any type 1 diagnoses. So exclusions are also something important to consider as you're building your phenotypes out. We are running a little low on time, so I'm going to actually skip the depression, but we can certainly come back to it in Q&A if people have questions on it. But I'm going to move on to this last phenotype, which is a phenotype that's a little bit different. So our GLP-1 phenotype is different both because it's medication-based and it's highly temporal. So if you'll remember for this study, for this one in particular, we're going to look at the phenotype where we were trying to assess the impact of GLP-1s on alcohol consumption, so a treatment effect essentially, meaning we want higher specificity. So for this, we also need to consider that prescription records don't necessarily mean someone is taking the medication. So, they might never pick it up or may have stopped taking it, etc. And then for our research question in particular, we actually need to identify who is actively on GLP-1s at a specific point in time, which is at the point in which they took the alcohol use survey. So keeping that in mind, our requirements for this phenotype was first to have at least 2 GLP-1 records on separate days. But this helps to ensure people are actually filling prescriptions and they're not just unfilled prescriptions. Second, we required at least 1 GLP-1 record within 365 days before the survey. So we wanted evidence of GLP-1 use near the time of the outcome survey. And third, we wanted the last GLP-1 record to be no more than 90 days before the survey or after the outcome survey. And so this tight time window tries to capture, active use of GLP-1 at the time that they were taking that alcohol use survey. So I think the key lesson here is that your study design really drives your temporal requirements. If we were just, characterizing GLP-1 users generally, we don't really need to think about the exact timing of when these GLP-1 records occurred. So I think that's really true for any phenotype where timing matters. You need to really think carefully about when exactly the condition needs to be present relative to other events in your study. All right, so now that we've discussed different phenotype requirements to consider and gone through some example, let's move on to the next step, which is creating concept sets. So a concept set is a curated list of OMOP concept IDs that operationalize your phenotype definition, and you need to create these before you can actually start implementing your phenotype. So here are kind of the typical steps for creating a concept set. So first, start with the existing resources that we mentioned in step 2, like VSAC, fee codes, or just a general literature review. You don't start from scratch if you don't have to. There's lots of great resources out there. Second, if the resources you found is not already in OMOP format, you will want to convert that to OMOP standard concepts, and then also pull in any descendants of those converted codes to capture all the specific variations. And then finally, in step 3, and this is really critical, is to conduct that clinical review. So you need to carefully review all the codes that you included. Ideally, this should be done with somebody that has like clinical expertise. And here you're removing any codes that aren't relevant and adding any codes that might be missed that are relevant. And then this process is repeated for each domain or phenotype element in your study. So let me show you quickly what that looks like concretely. So here's just an example of the different concept sets you need for our type 2 diabetes phenotype that I went over. So here we need 4 different concept sets, each for the type 2 and type 1, both diagnosis codes and drugs. So just to point out that, tip in a lot of phenotypes, you're going to end up creating multiple concept sets in order to put that phenotype together. All right, so now we'll move on to the final step, which is actually implementing the phenotype. So in the researcher workbench, you can build your phenotype using the cohort builder or using SQL queries. So just to first go over the cohort builder, which is more of a simplified way of defining a phenotype. So the cohort builder is really great for simple phenotypes where you maybe just want to require a single occurrence of a code or implement really basic temporal requirements or basic multi-domain logic. The cohort builder is really great for that. We kind of recommend it more for exploration and simple cases. But there definitely are some things to keep in mind as you're using the cohort builder that are not as obvious. So let's take a look at some of those. Um, so first, something to point out that's really important is when you are going in the cohort builder and adding concepts, especially for conditions, it's going to automatically add all descendant concepts, and you can't actually remove any of those descendants. So if there are descendants you want to include that aren't relevant to your specific phenotype, you have to actually exclude them in that separate exclude box. Second, when you require multiple occurrences of a diagnosis code or other lab result or something, this requires the same exact concept to appear multiple times, not just any concept for your concept set. So that's important to understand because it can affect your phenotype logic. And third, which is more of a pro tip, is that you can create your concept sets in the dataset builder before you start building a cohort. And that is very helpful to do ahead of time. So when you're going into the cohort builder, you can kind of quickly just add that concept set and make sure it's consistent across maybe different cohorts that you might build. So I think these are just some things we wanted to point out that might not be immediately obvious to new users of the cohort builder. Okay, so moving on from the cohort builder, you can also use SQL queries to implement your phenotype. And SQL gives you a lot more flexibility in defining your phenotype. So there are a lot of situations in which you really have to use SQL to define your phenotypes and not the cohort builder. And those really involve, more complex temporal logic, like, baseline periods, temporal windows, instances where you have to have complex logic across multiple domains. All of those kinds of things are going to require you to use SQL. So really it's advantageous because you can really do anything you want with it and implement any phenotypes you want. But with that being said, it is, more challenging. You need to know SQL, you need to understand OMOP, and there's more room for errors because you are coding from scratch. But I think despite these challenges, for any phenotype with complexity, SQL is really the way to go. And it's what I personally use, and Daniel as well, in our own research. So now that we've talked about all 6 of these steps, let's wrap up with some key takeaways. So first, overall, really want to hit home that phenotype definitions require deliberate design choices based on your research question. There's really no universal correct approach or correct phenotype. Each decision you make involves sensitivity versus specificity trade-offs that you need to really assess in the context of your own research question. And I think, we've walked through a lot of different principles and things to consider with phenotypes, but wanting to emphasize 3 really important things. And that's first, to really build on existing work, start with validated algorithms and things in the literature. Second, really make sure you understand your data and what's available. And then third, really importantly, get that clinical review. Whenever possible, partner with experts to review your codes and your phenotype definitions. But I think really the bottom line is there's no perfect phenotype, but there are defensible phenotypes, ones where you've made deliberate and justified choices based on your research question. So we hope the information provided today gives you a bit more confidence to tackle phenotyping in all of us. So thanks so much for your attention. I think we'll move now to the Q&A portion of the webinar.
Thank you again, Angela and Daniel, for this great and informative presentation. We do have several questions in our Q&A, and we're going to try to get to as many as possible. Okay, the first question we have is, do you have a checklist for the questions you use to walk through developing your phenotype definition?
Angela's been talking for a while, so I'll try and give her a break here. Take
Okay.
a stab at this one. So I do not know of an exhaustive checklist anywhere for developing a phenotype, and it's hard to think of a checklist because broadly speaking, the questions you're going to ask from one problem to the next are going to be similar, but these very specific questions you might ask could vary a lot from one research problem to another. Phenotyping is such a broad domain that how it is done is super variable. I would say that there's checklists of places to look for information. And so those can be external to all of us. So we mentioned the Value Set Authority Center, we mentioned fee codes. Um, and then previous literature also. So just searching for your condition in Google Scholar and seeing if there's anything published works that have value sets that you might draw from. And then there's separate checklists for where you might look in all of us for information, which could be the surveys and then all of the different EHR domains, like the condition table or the procedures table or the medications table. So I would say there's a constellation of checklists that you could maybe pull from, but I don't know of one place that has that information all together, unfortunately.
Thank you, Daniel. Okay. Our next question is there any general guidance for constructing a look back period with all of us data?
Yeah, that's a good question. I think obviously, it depends is going to be the answer. It really depends on your research question. But I think that, typically what I've seen and what I've done is a look back period of 1 to 2 years. And that's again going to change based on the exact condition. And you might want to consider when you're kind of like starting your index state might also kind of factor into how much look back you're going to want. But I would say in general, recommend either 1 or 2 years. I don't know if Daniel, you had anything to add there.
Yeah, I think that's great. The only exception might be if you're looking for incident disease, you may have an open-ended look back period. So if you were looking for incident MI, incident heart attacks, you might look, has there any history at all at any time of a heart attack before our study period? That's the only example I could think of where you might have that open-ended look back, is if you want to make sure you're looking for incident disease.
Great. Thank you. All right. And we have another question. Is it possible to demonstrate where specialty care visits slash departments are available in the condition occurrence tables, and how consistent is the harmonization for these domains?
Can I take a stab at that, Angela? It's not going to be in the condition occurrence table, unfortunately. So OMOP is a big, wide world. The two places that you might check if you're looking for that information are the visit occurrence table, which you can link to condition occurrence uh, via a visit occurrence ID. So you'd look in the visit occurrence table, or you might look in the visit detail table. And I say that you might look in those two places because of the second question you asked, which is how consistent they're coded. And for that, I have never had a ton of success trying to qualitatively describe the types of visits beyond the highest level. So you can pretty consistently find, is it inpatient, is it outpatient, is it ambulatory, is it that high level? But if you're looking for this was done at a cardiologist clinic, then sometimes it'll be there, sometimes it won't. What I would say is that if you're designing your study and that's critical, you're going to have to really parse down your sample to those where you have that information reliably. But if you're looking for that, this is a nice to have for the study, then I would keep it open and use it when you have it. That's one of those. There's lots of little pieces like this. It's one of those bits of information that is sometimes available, but you really can't rely on to be there.
Okay, great, thank you. And I think maybe one or two more questions here. We have one question. It says, since version 6, many OMOP concepts commonly used to identify pregnancy episodes were suppressed or removed, and these changes affected ongoing projects that relied on concept sets available in earlier releases. As a result, many researchers working on maternal fetal health are finding it extremely difficult to identify pregnancies or construct pregnancy cohorts solely from EHR data. Um, and they have two questions below. And they mentioned that while V8 appears to have partially restored some information compared with earlier releases, a large portion of pregnancy-related concepts is still available. So are there plans potentially to restore or replace these concepts in the future, or um, for now, what is the recommended approach for identifying pregnancy episodes under the current data structure?
Yeah, thanks for this question. It's definitely something we've encountered too. It is definitely a bummer that they've suppressed a lot of these pregnancy codes that allow you to really investigate the pregnancy. Um, we actually don't have, we are not actually part of the DRC, so we don't have any control over what's in the data, that kind of stuff. So we can't, unfortunately, we don't really know when they might update that data with that information. And as far as the best algorithms for looking at pregnancy within all of us, I would say we aren't necessarily pregnancy experts either. So, maybe relying on other experts in the field or just using the codes that are available. I know that's not the greatest answer, but, hopefully this, issue will be resolved and they'll get, more of those codes unsuppressed.
And I do think that the reason for the suppression was in large part to respect the privacy of those participants um, who terminated pregnancies or who didn't want to be identified because of their pregnancy. So it's a little bit tricky. Um, but yeah, I like Angela's point of this is a great example of where you would want a clinician on your team to help you figure out which codes you want to actually use for your problem.
Okay, great, thank you. And we have one additional question here. Someone asked, are there any thoughts about better ways to counter independent incidents of diagnosis from EHR?
So we typically will, there's many ways you can do this, mostly centered on the timing of those diagnoses. What we will often do in our research is just require them to be on separate days. If you are going to require someone to have two type 2 diabetes diagnoses, they might go to the hospital and get six of them in one day. So requiring they're on separate days is one way, but oftentimes for a chronic disease, you might require them to be at least 30 days apart, for instance. So maybe one day apart isn't good enough. And that's good. It depends on your question, depends on how selective you want to be in defining your cohort, but typically that's going to be centered around the timing of those diagnoses.
Okay, great.
That
And just going back to the question about the look back period, the commenter they mentioned that they are using observation period start date as the earliest date, and would you recommend an alternative variable for this?
I want to give
Or
Angela a chance. I think she has one more thing to say about the timing of diagnoses, but then also I
okay,
think she's can answer this question too.
Yeah, I was just gonna say that, like, taking into consideration what exactly you're studying. So if you're wanting to look at like every instance that somebody had like a stroke or a heart attack, to take into consideration like what is the length of stay for, a stroke patient or a heart attack patient. That can be really important to kind of really determining the timing between events. Yeah, and then in terms of the look back period, date and variable. So you can correct me if I'm misinterpreting this question, but from my understanding, you're kind of trying to assess what's the kind of earliest date somebody has evidence that they have EHR data in all of us. And for that, typically I will look at the earliest observation date in either the visit occurrence table or the condition occurrence table. So actual evidence that they've seen a healthcare provider is often, and I think it's like a visit start date or condition start date are those variables in the condition occurrence table and then in the visit occurrence table.
Okay, great. Thank you. Thank you so much. I think we might have time for just one more question. I know, of course, the information you shared is very sophisticated, but do you two have any advice for those who have only used a cohort builder but are interested in more advanced SQL methods, like you've talked about?
Yeah, I would encourage folks to start with a general purpose SQL introduction. So not necessarily diving into the all of us docs and trying to figure out how to access things through there, but just start with how to learn SQL in a Google search and find there's a million great introductions to SQL and just learning the basics of how those clauses have to be structured. Your select clause, your from clause, your joins, because fortunately, the EHR data, while very complicated and very messy, is just a relational data structure. It looks like every other relational database. And once you know how that works, then you can start digging into the data dictionaries that are available in all of us and start. And let me post maybe one link here, which actually covers the keys that link all the different tables. Um, and I'll just pull this link out real quick. If you scroll down, there's a figure on this link, and I'll send it to everyone here.
Okay.
Um, that that will show you how the different tables link together. And so I would start with just SQL by itself, basics of SQL, and then once you feel like you have a pretty good handle on how those basic SQL queries are structured, then try and link it to the all of us data.
Okay. Thank you so much for that, Daniel. Okay. Just before we conclude for today, I do have just two remaining announcements for everyone. We welcome and invite everyone to attend our next upcoming webinar in this series, and it'll be focused on planning your data analyses on the All of Us Researcher Workbench, and that will take place on April 20th from 1:30 to 2:30 p.m. Eastern. Here is a QR code below that you can scan to get more information and to register. And then also, I'd like to highlight that All of Us Science Day is upcoming on April 15th. This is a day to celebrate all of the great work that researchers are doing utilizing the All of Us data set. It's a free event, it's virtual, and it's open to everyone. And you can scan this QR code at the bottom to get more information. We will be sending out a copy of today's slides. So if you didn't get a chance to capture the QR codes or want to look at the slides a little bit more closely, we will be making those available to you. But I just want to thank everyone again for participating and attending our webinar. And also thank you again, Angela and Daniel, for your presentation today.
Yeah, thank you.
All right.
You.
I hope everyone has a great afternoon. Bye bye.